now we have over 100 participants. So I think we can very well start very well now. Let me see. Okay, great. So let me share my screen. All right, so once again, good afternoon. I think everybody can see my screen very well. My name is Dr. Iseko with Cardiocare Hospital Abuja, and like I said, Cardiocare Hospital is it's a focused hospital on cardiology and internal medicine, and we've been around for some time under the auspices of the Limi Hospital, which is over 40 years old. Cardiocare is almost 10 years old now and has been at the backbone of trying to reverse medical tourism, particularly in cardiology, cardiac surgery, and interventional cardiology. So I'm going to talk about how we perform and interpret coronary angiogram, especially in the setting of chest pain. We all know that chest pain is a very common thing that happens here in Nigeria. Dr. Taiwo, once you're ready, just let me know. I cannot see you. Chest pain is very common. It is one of the primary symptoms of a heart attack or a myocardial infarction. And so coronary angiogram is a test slash procedure that we use in visualizing the coronary arteries around the heart, and thereby we are able to find and treat any abnormalities that could have caused the heart attack. So greetings from Cardiocare. This is Cardiocare Hospital. Our cath lab is there. We're in area 11. This is one of the corridors in Cardiocare. So let me just give you a brief summary of what the procedure looks like. So this is the procedure as it happens. The patient is put in the cath lab. We'll have done a number of things which I will explain as we're going on. And while the patient is lying down in the cath lab, we typically will use the radial artery, that is on the wrist, or the groin, and that is the femoral artery. And then we get access with a needle, just like we do for an IV line. And you can see how that is done. Through that, we pass a wire and a catheter over the wire. And we pass that. These are specially designed. And we pass that carefully till we get to the heart. Then we withdraw the wire, and then we engage the coronary arteries. When we've engaged the coronary arteries, we give a dye, and that dye um, helps us to visualize the coronary vessels. So essentially, that is what is happening in this schematic video only. So you can see the wire now coming out, and now the catheter is now there. We now try and engage it, and then we give a dye. We typically use a non-ionic dye. And while we are doing this, we can see the blood vessels surrounding the heart on the left side. We do multiple views be able to see that vessel well. Then we go to the right side, like we are doing in this video, this schematic video here. Like we are doing in this schematic video here, and great. And then we're able to see the blood vessels on the left and on the right. That is summarily what happens in the coronary angio. And then, of course, I'll go into a lot more depth now. So first of all, we have the indications. We find out what are the indications for this procedure, and what will these indications show, and what will these indications show. So the indications, chest pain and the like, yeah, are all of them there. Then we now go on to the pre-op safety. So there are a number of things that must be done to make sure that it is a safe procedure. We've done thousands of procedures now in cardiac care by the grace of God, and then largely safe with international outcomes. Then we must get access, like you are seeing in this video. The getting access in this particular video is through the femoral artery here. But we also use the radial artery on the wrist. So that typically is nice, allows the patient to move immediately, move around quickly thereafter. and we can take it from there. But then here, femoral artery, we more commonly used, it's a bigger vessel. We can take bigger catheters, and we can do a lot more through the femoral artery, while the radial artery is a smaller vessel, a little bit prone to spasm sometimes, and we may start there and have to convert, but we give certain drugs to use the radial artery. So, and number four, after we have done that, we now access the coronaries. So the access to the coronaries is what we call engagement. Okay, I will go through all of this one by one. I'm just using this step by step just to give you an overview, a summary. Then we perform the angiogram, and then number six, we go on to interpret the angiogram, and then intervention where needed, and then we conclude. There are a number of things that happen in conclusion, including discussing with the patient and the family, doing a brief looking at what has happened, going through and maintaining hemostasis so that there's no bleeding, and so on and so forth, and then giving the patient appropriate instructions. So if you have any questions, please put them in the chat box and I will get back to you. Just a minute. All right. So the term coronary artery essentially is taken from the term crown, and it's thought that the coronary artery somehow, if you squint and bend your head to the sideways, it can look like a crown. Well, I can't see how it looks like a crown, but that is what it is. That is what it is named after. Corona crown from Latin. And then that is how we go about it. But notable is like we showed you, essentially, the main coronary arteries that come out as the left main and the right. And occasionally we have, I think 3 weeks ago, I did a case where there were three different origins. The right coronary, and there was no left main. The left circumflex and the left anterior descending both came out from the aortic cusp. So occasionally they are natural or normal anatomic variants that happen from time to time. All right, so number one, how do we go about it? We're going to go through these 7 steps, and I expect that you will be very well highlighted. So number one, what are the common indications? The first and most common indication is an acute coronary syndrome. Patient presenting with ongoing chest pain. And Dr. Taiwo, when you are ready, let me know. Patient going with ongoing chest pain. Somebody's asking, where does CT coronary angio come in the diagnosis? So I'll talk about that down the line. So just hold on. What I'm talking about now is the invasive coronary angio, not CT. So acute coronary syndrome essentially is patient having severe chest pain. And if you watch our previous webinars, please click on our YouTube channel, Cardio Care on YouTube, or go to our website, cardiocare.ng/webinars, and you'll see where we went into detail on this. So for acute coronary syndrome, essentially most times patient is having severe ongoing chest pain, and more often than not, the cardiac enzymes are elevated. Now, when we put that together, we have to go in straight to do the coronary angio to stop death. Really, patients that get a PCI, coronary angio intervention, early during their acute coronary syndrome reduces the risk of death by up 30 to 50%. So that is quite important, especially over the first 1 month. And so patients with acute coronary syndromes is normally one of the most. Then we have stable angina with high switches. Especially patients, what we mean by stable angina is that a patient is having chest pain when they shout, when they run, when they walk, when they are angry, but when they rest, it goes down. So that is stable angina. Most times it's chronic. Whenever they do anything strenuous, sexual activity, they feel the chest pain. When they relax, everything comes back down. So that's what we call stable angina. Now, there are certain high risk features, especially people that have, positive angina, persistent angina, despite optical medical therapy and some other things. those with a positive stress test, then those with an abnormal non-invasive test. And if somebody were not sure whether, especially in an inconclusive stress test, the chest pain did not look normal, we went and did a coronary CT angio, and it was abnormal, those people also will have to go on for this coronary angio. And then for some people going for preoperative assessment, especially those going for aortic surgery or for other cardiac surgery, we don't want to go and do a cardiac surgery for something else only to find out that there was coronary issue. So if we're going for cardiac surgery for any other reason at the same sitting, we just go ahead and we do coronary angio, so that if there's something that needs to be done, we can fix all together at the same time. Then when we are assessing patients for heart failure or cardiomyopathy, patients presenting with sudden cardiac arrest or life-threatening arrhythmias, when we are assessing anomalous coronary arteries, especially when it's symptomatic, and then patients with persistent or recurrent symptoms. They've had a stent done or they've had coronary artery bypass grafting surgery done before, and they are still having persistent symptoms. All of these are just a few indications, but these are likely the most common reasons. Anybody having chest pain with a heart attack now must have a coronary angio, typically within 60 minutes of the chest pain starting. Don't wait one day, don't wait till the next morning before you refer. It is critical because they could die. Then patients that have been having ongoing chest pain on and off, typically stable, people with abnormal tests and all of these. These are very important reasons why we do a coronary angiogram. So let's go on straight. So if you remember this cardio care algorithm for chest pain, which we have presented over and over again in Nigeria, what we are saying here is that when you have chest pain, please refer to a cardiologist or refer to cardio care if you're unsure. And this includes ulcer pain. This includes ulcer pain. We do a lot of the patients we see that are coming very late, that are coming very bad, are those that have been treated for quote unquote ulcer on and on and on. And then they finally either they came by themselves or got referred, and then we found out they're having a heart attack. So patients having chest pain, please do an ECG immediately. Chest pain, ulcer pain in an adult, do an ECG immediately. So within 12 leads, within 10 minutes of presentation to the hospital, they must have a 12-lead ECG. So, and then clinical evaluation, and then we assess the cardiovascular risk. So depending on whether the troponin is normal or abnormal, in most cases, we want to add a troponin test. Whether the ECG is abnormal or normal, we want to add the troponin test. Remember that an ECG could be normal initially in a patient ongoing with an ongoing heart attack. As much as 10 to 13% of patients are wrongly discharged from emergency rooms in the United States with a heart attack because they felt the ECGs were normal. So it's very important that if patient is still having ongoing chest pain, the normal ECG does not necessarily rule it out. Repeat that ECG again in 3 to 6 hours if there's acute ongoing chest pain, while you're looking for other things that could have caused it, and do your troponin test. So very, very important. So these are the things you do. Then we now decide for those that have positive troponin and positive chest pain, we do an angio. For those with an intermediate risk and high or suspicious echo or intermediate pretest probability, we do an angio. And those with intermediate pretest probability with positive stress test, we do an angio. And those with normal ECG with high risk, we typically will repeat and make sure we have the troponins done before we decide about angio. But if the patient has no risk or maybe low risk and they have normal ECG, normal troponins, we normally will start looking for other causes, pneumonia, anxiety, aortic dissection. That is a life-threatening one. All of that could be there as a cause of chest pain. Now remember we've talked about this. I'm just going through basic stuff, that every time you have a chest pain, you have ECG. On the ECG, you use this first thing called the TP segment as the isoelectric line. For those that cannot read ECG, if you go to our webinars, our library, you should be able to see a video and you'll be able to read an ECG if you went through that webinar properly. And then we follow it. At the point just after this J point, like 1 or 2 boxes immediately after, if you can see my red arrow, that is where we assess the ST segment. And if that ST segment is depressed or elevated, especially if it's in similar leads, we say that chest pain should automatically and urgently get to a hospital with a cath lab like cardio care hospital, so that you can have an urgent emergency coronary angio. And if there's a blockage, it can be fixed immediately. So these are you may need to cram this if you don't know this already, or write it down, or take a picture of the screen. If you have that ST depression or ST elevation in any of these leads, especially where you have it in 2 or more of these similar leads, you can see how we have grouped them as similar leads, then it means that that ST depression or elevation is very significant, and that chest pain is very likely due to a coronary artery obstruction. This is very important for us to know. I'm sure that we can take this very well. If you have any questions, please put up in the Q&A box. We are not yet in the meet. We are just doing a brief introduction while we're going to the meet. Thank you, Prof. Ogumodede. We are very happy to see you, sir. Okay, I'll talk about that as well. All right. So again, for those that are just joining us, we talked about the coronary angio. Patients should be ideally do it in a cath lab. Now we know of patients. So Ogumodere was asking about patient dying on the table during coronary angio. So I know of people that sometimes use C-arms or other things to do a coronary angio. Sometimes that can work, but if you run into trouble, you're probably on your own. So we told you that we get access. First, we know the indication. Then we do certain things that we consider very important for pre-op safety. We get access typically through the femoral arteries or the radial arteries. We typically proceed with a wire. Then we proceed carefully over the wire with the catheter. And then we secure access to the coronary vessels, what we call engagement. Then we proceed to do the angiogram. And doing the angiogram is nothing more than injecting a special kind of dye into the coronary vessels. This is typically done while the patient is awake. And beyond that needle prick, they should have no scars or no problems thereafter. Okay. A coronary angiogram is largely safe. Typically 99%, 99.5% safety, no issues, no complications. And so we now are able to do the angiography, and we can see the blockage. So we interpret that problem, and then we intervene where needed, and then we'll conclude. I will show you some cases that I've done in cardio care so that you can also see. Welcome everybody that just joined us. I can see we have over 170 participants in this. So number 2, so the first we talked about was indications, and we talked about how you can identify the ECG, and we talked about knowing how to identify a heart attack. And we said, okay, you can also go back to our webinar library and get access to all the ones we have done on heart attacks and on different ones. Now, number 2, preoperative safety. Safety is the watchword. Very, very important. This is, in my opinion, even more important than the procedure. And sometimes some people miss this out. So this is very important. If I'm interviewing or I'm examining cardiology senior residents or cardiologists, this is one thing I will ask them always. And for the cardiology senior residents on the call on this meeting now, you should be prepared for this for your part 2 final exam. And what are some of the things that are there? Number 1 is a full medical examination. A full medical examination. You must have a full idea of the history of what brought the patient in, or what are the mitigating factors, and be ready for it. Then we go on to so key points in the history. New oral is quite important in coronary angio, and sometimes patients tend to feel like vomiting or have nausea when we give the dye. So it's very important that they're typically up to 4 to 6 hours new oral. However, if it's an emergency like an MI, we go ahead without this. Does the patient have any allergies? Are there prior medical conditions, previous surgeries, medication history? Have they had anticoagulation? Metformin is particularly important because of its effect on the kidney, and then when we give the dye, sometimes that could worsen it. Then check, have you signed a consent? Remember that it's a procedure, and the ethical thing to do is to make sure that an informed consent is signed. Even though we know that this procedure is likely safe for most cases, over 99%, there is still a possibility of complications which can happen with any procedure just like this. A full medical examination and, very important, signs of cardiac decompensation. One of the things that we have noticed in our center is a lot of patients presenting very late with a heart attack, already decompensated in heart failure, very sick, blood pressure is very low, and we've had to do cases with these very difficult situations. So you must have known the extent of what is happening and the amount of support you will need. From either you have to intubate, you have to get more cardiologists in the room. Typically, we have about 5 cardiologists. You have to get more people in the room. What access point will you use? How quick must you be? And so on and so forth. And then full blood count, HIV, hepatitis B, and the like. ECGs must be done. If they have previous angio, it's very important. Don't say that you know it all. You need to review that previous angio, because there could be something that could have gone wrong in the previous center. If you see it ahead of time, you too will not fall into the same trap. And then typically hydrate the patient a little bit, patient preferences. Number 2, make sure that the patient has IV lines. Your crash cart is up to date. It is stocked. IV adenosine, nitroglycerin, amiodarone. And for those that were available at the last Abuja Cardiovascular Symposium, we shared with you a full list of what your crash cart will contain in the hospital, talk less of in the cath lab. You must have a functional defibrillator, and not an automatic one. You need a manual one. And I'll tell you the reason why. Because you don't have time for the machine to be analyzing. You need to be able to deliver a shock as soon as it is needed. So Prof was asking in the comments, that patient had died on a cath lab table somewhere and was wondering sometimes what are the things. So if a cath lab must have all of these things ready and on hand as much as possible, because sometimes when you give the dye, patients can react. Patients can have a VFib. Patients can be very sick as you're trying, they could have that. And if you cannot defibrillate immediately, you will lose that patient. Or sometimes patients will need a temporary pacemaker while you are doing the procedure. So if the person goes into a heart block, the temporary pacemaker will take you through, you finish the procedure, open up the blood vessels, patient is fine. I've had to use this on several occasions. Now, we know temporary pacemaker is quite expensive, but it is life-saving, and you should not really be doing a coronary angio without having some of these things on hand or nearby within your reach. Also, intra-aortic balloon pump, informed consent, oxygen, you must check it. You cannot start the procedure and oxygen finishes. Echo and ultrasound. You must have all supplies for all anticipated problems. Anything that can go wrong will eventually go wrong. And so you must have everything ready to tackle any possible outcome. And surgical support is a good idea, not always present, but it's a good idea. But we know that there have been several studies that have done to check whether it is safe to do coronary angio without surgical support, and it has been shown to be perfectly fine in the US, and many centers in the US do not have surgical support. However, if there's surgical support nearby, they should be alert, or they should be around on ground to know about it. Okay. Then you do your pre-op assessment, you do your pre-op, and then don't forget you must do a timeout on table. You could have the wrong patient. So occasionally we have as many as 9 patients to do in a day of different procedures. And if you don't do this on table timeout, you could mix up a patient. You could have the wrong patient in for the wrong procedure. So this timeout is critical, and I dare say it is a key medical legal issue when it comes to procedures generally, and particularly in the cath lab. So a pre-operative on-table checklist must be done. You should have a pre-operative information session with the patient and the family. Okay, so we've talked about indication, we'll talk about pre-op safety. Next, we'll go to access to the blood vessels, and we'll talk about that. So access to the blood vessels. Typically, we use 2 sites. Some people have tried using the brachial artery, but by the time we studied that over time, we realized that it's not the very best, very difficult to achieve hemostasis, and bleeding could be a big problem. So femoral is easier, but the patient is typically more comfortable with radial. Radiation exposure is thought to be slightly better with femoral. Bleeding complications are better with radial. Cost radial may be slightly better, but in Nigeria, sometimes radial is actually more costly. So these are some things we use to determine. In patients presenting with an MI, generally it is said that radial is better, and for a number of reasons. In Nigeria, particularly, a lot of our patients present late, so they're already in heart failure. So if you need them to sit up, and if you have put a radial sheet in, you may have a problem. But if it's on a femoral sheet, you may have a problem. If it's on the radial sheet, then it's a lot easier. So those are some things that, and then radial, of course, has less bleeding because it's from the hand, it can easily be controlled. While especially a patient is very fat or obese, femoral could have bleeding and bleeding internally. So those are some things you will look at. So determine the access options. Everybody doing coronary angio should be able to do both, and I do both. Although we do more femoral, but we do both depending on the situation. So look, is there any reason why you want to use the femoral, the radial? Sometimes patients have known femoral disease or aortoiliac disease. Maybe patient has had previous calf that showed a problem while doing this. If they have dialysis shunt in their arm, you need to go to the leg. If they have had a kidney transplant, most times they put the kidney in the pelvis, you may want to go to the radial. So we've had to do for some patients post-kidney transplant or around kidney transplant, they may have an already femoral vein access. You may not want to have any problem putting this. So all of these things are things you will consider. Some people have a lot of difficulty lying flat. When we use femoral, patient typically has to lie flat for 6 hours after the procedure. And, so you must make sure that the patient is able to do all of these things. Now, if they have a STEMI, you want to consider more radial. If you think they are on oral anticoagulation or they are a high bleeding risk, you want to do more radial. But if you think you are going to end up with a complex PCI that may need a bigger sheet, that may need multiple balloons and stents, you want to definitely be in the radial because it's a bigger vessel. You can pass more equipment in and you can really, get in there. And if you don't have time, femoral sometimes can be a lot faster to get you straight in. So those are some things you should consider. Thank you all for joining us. I can see we have over 180 people present. This is courtesy of Cardio Care Hospital, a hospital in Abuja, Center of Excellence for Cardiovascular Health and Cardiovascular Medicine. We are focused on interventional cardiology, cardiac surgery, and university medical tourism. So we're just going through coronary angio and giving an insight into how it is done and key things that we should note in the coronary angio. So these are all the things we talked about, especially patients with heart failure. And I particularly noted a lot of Nigerian patients presenting with heart attacks. We have a series which we'll publish very soon of all the heart attacks we did over the last 1 year. And most of them presenting very late, already in heart failure, cannot lie flat, difficulty in breathing, pulmonary edema. So most of them, you have to try and use the the radial, so that they can actually sit up a bit. That would really help you. So this is a patient, for example, this is taken from this article by Taggart. Patient had bilateral radial artery harvesting for a coronary artery bypass grafting. Of course, obviously for this patient, you cannot try to do radial. So I'll just talk about femoral access quite briefly. If you have any questions, please remember we have a Q&A box. Just put it into the Q&A box. And then we'll answer them. Some I'll answer them as we are going. Dr. Kwebo, thank you for joining us. Please, do you also give heparin prior to cannulation in coronary angiography? So typically, some people have talked about giving heparin. I'm just answering one of the questions in the chat box. Some people have talked about giving heparin for coronary angio. But generally, as a rule of thumb, most operators worldwide do not routinely give heparin before routine coronary angio. If you are using femoral, now if you are using radial, you typically will have to give heparin because the vessels are smaller and the tendency to clot is very high. However, if you're using femoral and you're just doing coronary angio using femoral, you probably will not use heparin except you want to stent. So typically we just make sure that all your saline is heparinized, very small amount of heparin in your saline that you use to flush your things. or will be heparinized. But apart from that, we do not actively give heparin. We typically give heparin only when we want to deploy a stent, when we have seen a blockage, we want to start intervening the coronary vessels, then we'll give heparin. But if we are using radial, we typically will give about 5,000 units as we are doing doing that. Dr. Taiwo, like I heard your voice. Is that your voice?
Yes, sir. I'm here, sir.
Yeah, I can't still see you. Are you showing now? Okay, so Taiwo, if you have anything to add, please just pop in. I can't see you, so it's very difficult to coordinate.
Okay, sir.
Okay. So Dr. Taiwo thank you, Dr. Taiwo, for joining us. Dr. Taiwo is one of the cardiologists senior cardiologist in Cardio Care Hospital. So she has joined us a lot for the coronary angio, and she will recognize this very well. So typically, we feel the femoral pulse. There are several ways to do this. There's using under fluoroscopy to guide fluoroscopy. There are landmarks we can use. But by and large, one of the most common ways or the safe ways to do is to do it under ultrasound guidance. That will help give you a clean puncture, little bleeding, no problem. And then some people also do it blind. That's also possible. So after you've located your pubic symphysis, anterior superior iliac spine, your femoral pulse should just be right there in between. We don't want to go too low or too high. If we go too high, we could puncture and cause retroperitoneal bleed. As you can see in this picture, schematic picture where my pointer is. If you go too high, when you finish the procedure and you are coming out, they could be bleeding straight into the abdomen and you will not see any bleeding here. You think you're fine. If you go too low, there will be not enough tissue for you to compress that vessel again. So we typically like it to be at the level of this femoral head. So when you are compressing the artery to stop bleeding, you will compress it against that femoral head. So very important. So when we do that, we palpate, we make sure we've draped the person, we do fluoroscopy of the femoral head, make sure that we are the correct side, and then we'll now go ahead with anesthesia, local anesthesia. And remember that coronary angio is typically done with the patient, you know, awake. Doctor, anything you want to add?
None yet, sir.
All right, great. So, and then if you have any questions to just ask, anything that you think somebody will want to ask, just help me ask me so that I will just answer it in case I just keep on ranting on. Okay, so
Okay, sir.
as you can see, the patient is well draped. You've cleaned typically with iodine. It's a sterile procedure. You've felt the thing. You've done your fluoroscopy. So I'll go through it. So typically what we'll do is we put a small artery forceps, put our fluoroscope head over it, and then we are going to see, because we don't want to puncture too low, like I said. If you puncture too low here, when you want to press and compress after the procedure, there will be nothing to compress. Patient can bleed and bleed into the thigh. And if you go too high too, you're into the abdomen, the patient will bleed into the abdomen. So you want to be just at at a good position around the femoral head where you can have space to compress against. Then you can use your ultrasound. Typically you have it and you can swing it, put it across 90 degrees and you can swing. Very important why you use ultrasound. Ultrasound helps to make sure that you don't go and have a puncture, because when you are palpating, you might palpate these branches, profunda or superficial femoral, and you might think that is the femoral artery, and you might go and puncture there. And you could have a very nasty result. Or you might enter a smaller vessel. So when you're using ultrasound, you can see the vessel directly. It has been shown in studies to reduce bleeding. But of course, you can typically also use manual palpation for that, as many people do. So if you use ultrasound like this level now, you might think you are there, but really you are below the bifurcation and you might go and enter the profunda. But when you use the ultrasound, you can be able to see above. And this was published in JACC in 2017. So once we get in, we've got into the vessel. This is a standard puncture needle. Then we advance. Now there's also some room for what we call a micropuncture kit. A micropuncture kit is similar thing, only that is a smaller needle, a thinner needle, and a smaller wire. So that if you miss, the bleeding that will come out will not be much at all. So a lot of people also advocate for that, but most of the studies have not shown any significant difference in outcomes, but occasionally, but that adds significant cost to the procedure. So once we get the access, and it's similar for the radial, once we get the access, next thing we put in a wire. This is a 0.35 wire, 0.35-inch wire. That is the thickness of the wire. So we use 0.35-inch wires typically for peripheral vessels. We could also use a 0.14 wire for peripheral vessels. I mean, not 0.14, 0.18, sometimes for distal leg vessels. But for these major vessels, we use 0.35 wire. When we are entering the coronary vessels, however, we use 0.014, much smaller, more tinier, more thinner. Okay, so then we pass the wire and then we can pass our sheet. Now, there's a rule of thumb in coronary angio. Never advance anything without fluoroscopy. So you might be passing your wire and think the wire is going. Meanwhile, you could be going to this lateral circumflex. You go and put your sheet there, and that lateral circumflex is typically a very small vessel. You go and rupture that place, patient starts bleeding internally. You may not even know. Okay, so those are some things that could go wrong and that you should not do. So you typically do it in your cath lab. You can see your wire going up very well. Then you can now pass it. Okay, so if we look at this, you ask the question, what went wrong? What went wrong? So the thing that went wrong in this case is nothing more than the hand of the fluoroscopy of the surgeon. The hand of the surgeon. This is a bad thing. You should avoid it as much as. Remember, your hand is not protected from radiation. I think I forgot to add. I left out that slide on radiation safety. There's a lot of radiation in the cath lab. So you want to be as far away, you want to be properly leaded, and you don't want to overexpose yourself to radiation lest you have any problems later in life. Okay, so for example, I've been doing this for up to 5 years. You can only imagine the amount of radiation that I've taken. But we have ways of checking these things and making sure that it's safe. So it's largely safe for the operators, and there are many people that have done it. So good position, good course is going the correct way, but be careful about showing yourself. After the wire has gone in, you typically will press and pass your sheet over the wire. So this wire has gone in. So this wire acts like a track, like a railroad. You're going to use that to just pass across your sheet. For those that have done punctures for dialysis, it's similar, only that in this case, we are using the artery, and you see the artery is bright red and it is shooting out. Sometimes the patient's blood pressure is over 150. As soon as you puncture from that needle end, it will shoot out, fiam, almost touching your face if you're not careful. So typically it will shoot out, then you pass your sheet over it. Sometimes the skin is too thick. Occasionally you may need to make a small nick on the skin so that it passes through. Then you flush the sheet. Very important. Once you pass it in, you need to flush that sheet. Why must you flush the sheet? You may have carried across debris. There could be a small clot inside, and you don't want to push that clot in. Okay, so the first thing is to aspirate the sheet. Anything, you need to aspirate at least 3 to 5 mils of blood out and discard. Then you now flush with a hyperenized saline. Okay, and then typically you should do a femoral angiography before you continue to make sure. Why is this important? Occasionally, some people have inadvertently dissected this vessel. That is, your wire went under the inner lining of the vessel and it caused a problem, so that you can see it early and stop. Or something went wrong, or your vessel entered the wrong vessel, your sheet entered, you can see it early and stop or change. Okay, so it's very important to do a femoral angiogram before you start, and sometimes even after you're done. Okay, so again, remember we said the procedure goes on, indication must be right. There must be a reason for that patient to be in the cath lab. It cannot just be a routine test, because there are risks, like we said, even though it's less than 1%, there's risk of radiation to the provider, and then there's safety that must happen. We talked about all the pre-op safety that must be done, and we've talked about access now using largely femoral access, but also radial access. The only difference with radial access is that we use a smaller radial puncture needle, and because the radial artery is prone to spasm, we typically will give a cocktail of drugs into the radial artery to stop it from having a spasm. It's typically very painful. So we stop that, and then we'll now continue through the hand. Quite nice, smooth. Then we now go to access. After we access the vessels, we access the coronaries before the angio. So coronary artery engagement, coronary artery engagement. So for all those, we still have over 180 people joined up. Thank you for joining up. If you have any questions, put in the Q&A box. The slides will be available at the end of the over the next few days. We'll send the slides to your registered emails, and you can rewatch this presentation on our page cardiocare.ng/webinars, or directly on our YouTube page, together with many other things which we do for free. We've been training for quite a while, just to establish these things in Nigeria. All right, so coronary artery engagement, you've gotten in now. You've gotten into the vessel. You've done you've passed your wire across. You've passed your sheet. You flushed the sheet. You've done your femoral angio. Good, beautiful vessel. Sometimes too, you do the femoral angio and find out that the femoral artery may be blocked. Something may be wrong, or there might be an aneurysm. You have to just stop so that you don't have any problem. So you've done all of that now. Now it's time for your access to get to the coronaries. So first is that you advance your guide wire to the root, and you can see the guide wire. I hope you can see the guide wire in this. I hope we can see the guide wire in this. Let me show you. We can see the guide wire there. Yeah. So we can see the guide wire there. The guide wire is J-shaped. You can see it's J-shaped, so that when it enters into the vessel, it does not pass through the vessel, does not tear it, even though it is blunt, but it is still J-shaped, just to make sure that it's going in. There's little or no chance for problem. So pass the guide wire like that. How do I end it? Okay, good. So we pass the guide wire. We select the catheters correctly. Now, selecting catheter, there are a number of things to go into, but I will not go into, since this is not an interventional cardiology class for senior registrars or for consultants. So, but there are things you should consider, whether you are using a diagnostic versus a guide. I will explain to you. A diagnostic catheter is one that we just use to see the vessels only, while a guide catheter is one that we use to determine, that we use to treat. So it has a wider inner core. We can pass stents through it, we can pass wires through it, and through that same catheter, we can operate on the coronary vessels. So that's the difference between the guide and the diagnostic. The guide and the diagnostic. Now, they have different shapes depending on what you expect to meet or the particular characteristics of that particular patient. Then we choose different sizes. Typically, for most cases, we use 6 French. Typically, diagnostic or basic cases, we use 6 French. However, in complex cases, you might have to use 7 or 8 French, where you need a bigger guide to pass multiple balloons in at the same time. Typically, when we are doing bifurcation cases, most catheters are standard length, and then some have side holes. Very important about side holes. Side holes are very good for catheters, but occasionally they can deceive you. So a side hole is on the side mouth of the catheter. It goes into the coronary artery. If the ostium of the coronary artery is narrowed, we need something that has a side hole so that it does not obstruct the flow. But it's very important. So we choose different vessels depending. So for the right, we typically use a JR standard more often than not. For the left to standard, we use a JL for diagnostics. Okay, that is it. But if a patient has had coronary artery bypass graft, then it now becomes a little tricky, and there are so many other multipurpose catheters, Amplas left, Amplas right, that you might use. Sometimes it's not very easy to get these vessels, or sometimes we need more support while we are doing it. So we might use Amplas left or the like. And you can see the ones in red, they are the guides, the ones we typically use when we are, treating something, not just doing a diagnostic. So one of the typical ones we use more often than not is the EBU or XB. EBU means extra backup. It just gives extra backup. So when we pass this guide in, or the catheter in, it goes in like this, comes in, and it just sits here. I hope you can see my annotation. So when we pass the catheter straight from the femoral right down, it goes in like that, comes out. So it goes in like that, typically rests on one of the cusps, and it doesn't even need any serious skill per se. It just gets in like that. So this EBU is one that has extra backup, so that when you are trying to pass in equipment and there's a very tight blockage, it does not push out the guide from what you are doing. So that is the EBU. But JL also sits like this, but it does not give that much support. And the other ones have different shapes, which I will not bore you with. So we're talking about this in this case. So by the time we come here, you can see us passing the guide wire through it. Remember that the guide wire must go ahead. The catheter must not go first. The guide wire must go ahead of so enter first with our catheter. Once the catheter enters the sheath, remember we passed the sheath before that we used to do the femoral artery angiogram. Then we pass this in, and then next thing we advance the guide wire first. So you can see the wire, pass it in ahead, and it goes ahead of the catheter all the way. We don't want the catheter, remember the catheter is bent and curved in a particular way. We don't want that catheter to scratch the wall of the aorta as it's going up. So the guide wire goes and acts like a rail, so that this now goes up a little bit straightened and goes on that rail without scratching the sides of the wall of the aorta, which could cause dissection or very severe problems. So if you see the wire going up, this is a patient that has had a coronary artery bypass graft. You can see the wire they used to tie the sternum together. And the wire goes up like a rail straight across. Then after it, you can see the catheter coming, and then we pull out the wire. Okay. And in an EBU, same thing. That J-tip wire goes in, and then we pull out the wire, and then we are in. It looks very simple. It actually is very simple. I don't know if there are any questions so far, but if you have questions, just put them in the chat box, and I will attend to them very well. Okay, so somebody says, is intra-arterial blood pressure monitoring required during coronary angiography? If yes, how is it achieved? Fantastic question. Let me see if I can get something. Well, I will explain to you. I did not put it in this slide, but I will explain to you how we do the intra-aortic valve. So intra-aortic pressure is critical during coronary angiogram. It is critical. You cannot wait for your blood pressure to start reading, inflate the cuff, then gradually come down before you realize what the blood pressure is. You need to know the instantaneous blood pressure while you are doing what you are doing. I think there's a slide here. I'll just check. While you are doing what you are doing, that helps you to know when problem is happening. So anybody that is doing these things without those things normally puts the patient at severe risk. So that intra-arterial blood pressure is critical in this. Also, when you take your vessel your catheter to the coronary artery mouth, we look at that. So this number 6 on this our steps to engagement, that waveform we are looking at is that intra-arterial blood pressure monitor. If this catheter is against the wall and not inside the blood vessel, we will be able to know it from that catheter. So we connect the sheath. So that catheter, we connect it to a 3-way. So somebody says, how is it achieved? The back of the catheter, after we have removed the wire, we now connect this back to what we call a manifold. That manifold has multiple junctions. One will be connected to the pressure, to measure the pressure. Another one will be connected to saline. Another one will be connected to contrast. And sometimes there's a fourth one for giving drugs while you are inside the vessel. So you have those 3 or 4-way manifold connected to the back of this catheter, and then from there we're able to measure. So from there we now do, once you are pushing the wire, the golden rule, another golden rule, you never push hard. If there's any resistance, you stop, because patients could have the aortic dissection, you may not know. Patient could have a flap, you may not know. Your wire could be going in the wrong direction, you may not know. So if you feel any resistance, you stop. Look at it very well. Look at your arterial waveform. That will tell you which direction you are going. And then you can now decide. So step 1, after your guide wire advancement, check the transducer. That is the arterial pressure. If the pressure is good, advance the catheter, and if it's not, reposition. You may have to give a vasodilator. You may have to change access, especially if you're using radial. If you are using radial and you feel any distance, like you have a spasm, you cannot continue pushing. You either have to give a vasodilator, you may have to change from radial to femoral to complete your case. So this is what we do typically in this. All right. Now, sometimes there could be a side branch. You're trying to pass it across and then your wire enters a side branch. Okay, so those are things you will do. So when you have passed it all to the aortic root, before you finally engage the coronary catheter, you bring out your wire, you connect your manifold, you aspirate your catheter. Very important to aspirate that catheter. There could be small clots, there could be small debris, there could be small plaques that have gone all the way. And if you just flush it, it will flush into the system and cause problems. So first and foremost, aspirate that catheter. Okay, when you have done this for a while, like we have done, this comes almost reflex. Then after you've aspirated the catheter, if you cannot aspirate, you withdraw the catheter. That means that catheter is against the wall. Then you connect your manifold, everything is going on, flush the manifold, and then that is now okay, like this. So you want to flush the manifold, you want air to come out, you want every other thing to come out, and then if you have smooth flowing, in some cases, like you can see this in this slide. I don't know if you can see it. Let me use magnifying. You can see in this slide, this was inside the catheter after just passing it in. If you just push this in, you will never forget in a hurry. And sometimes there could be a clot that could be there, so that could have passed across. So you need to aspirate, get everything out, make sure that it's flowing freely. Then you connect your manifold, you flush everything, then before you now go on to the coronary arteries. Good, thank God I had a picture. Somebody that was asking about in the Q&A box, somebody asked about how do we check the pressure, interarterial blood pressure. So like I said, this is the manifold. This is the manifold. One you can see is connected. So one of these will be connected to a pressure transducer. And that is connected to your monitor. So your monitor, you will not only be seeing the blood pressure monitor, you'll be seeing the blood pressure tracing. That blood pressure tracing is critical. You must know how to interpret it. Even though you are seeing the blood pressure normal, you must be able to interpret that blood pressure tracing. So you connect the manifold, you can see all of this. So one is connected to contrast, one to saline, one to pressure, another one for waste or for giving drugs. So that is sometimes how it looks. Okay, so now we now look at it at this now. We can now see when catheter is engaged or not. This is the waveform I was talking about. I hope you can hear me. Yeah. Please, can you indicate in the chat box if you can hear me, please?
I can hear you, sir.
Oh, great. Okay, great. All right. So, great. So I'll just continue. So once you will now manipulate those catheters. I cannot teach that over Zoom. Sorry. If you want to come around to cardio care, and I will oblige you. So once you've engaged the catheter, you now look at your waveform before you do anything else. You could have engaged the catheter and you could be against the wall. So you will see the pressure going down in some cases. This is a case where there is an ostial stenosis, where the mouth of the coronary artery is very narrowed already. That is likely the problem why you're even doing it. As soon as your catheter enters it, blood pressure crashes down. So if you don't have this interarterial pressure, you will not know. You will just continue doing your this thing before you know the patient is having a cardiac arrest. So as soon as you do it, even if you look at the ECG, you see there's some S segment depression that changes. So as soon as you entered, you saw this one, you pull back. Once you pull back, it came back normal. This patient is likely having a very tight occlusion at the ostium. So you engage, you disengage. So these are the kind of cases that you need a catheter that has side holes. Okay, or you have to do it without engaging the coronary. What do you mean by engage means that entering the coronary artery. Remember, you're taking your catheter just to the aortic roots. Now you want to just engage the coronary artery. So you manipulate. So if you don't have a good waveform, do not inject. Aspirate again, check again. So in this case, see what was there, clots. If you inject, the patient has an MI on the table. So we now use that. So the way we manipulate the catheter, we use the left hand to go front and back, while we use the right hand to turn left or right to rotate the catheter. So we manipulate it after we have gotten. So let's look at this. Wire comes in, we pull out the wire, then the shape comes out. As we pull out the wire, we now engage the left main. These catheters are specially designed by different people who have made plenty money, I'm sure, from their special designs, so that they just come and sit down here and they just go straight if you have the correct size. Now, sometimes it might not reach or it might be too long, so you might have to change the size, but ab initio, we typically have a way of sizing for most patients to get the appropriate size. So it sits down here and is able to get in. So we're teaching coronary angio for everybody. Our hope in cardio care is to make this like bread, make this every day available to all. So for some of you, it may seem too high, but just keep it in your mind. It's something that you use. For some of you, it is too low. But for all of you, it is likely going to be something you can easily follow. And if you have any questions, please just highlight in the Q&A box and I'll stop and I'll re-explain. So we pass that into the left and we'll do a similar thing. If it's in the right, we remove the wire and then we engage it into the right. Quite simple procedure. So now I remember I said, make sure you have a good waveform. Never inject if there is not a good waveform. If you inject and there's no good waveform, you will likely cause problem and patient can die on the table. So those are some of the things that are critical. So when people try and do the procedure outside a cath lab without all of these measuring tools, they typically could be in trouble sometimes. All right, so we're showing the procedure of coronary angio, and we said first is make sure that the indication, I'm just giving a summary as we go on. We've gone through the indications. We say acute coronary syndrome, determined chest pain, MIs, heart failure assessment, patient having ongoing chest pain with high-risk features, different other reasons we have shown that. Then we talked about the safety things you must do in terms of evaluating the patient, evaluating yourself, doing your timeout. Then we talked about access and we showed how to do it from the femoral vessels. And then we also talked about radial vessels. Now we've talked about coronary artery engagement and we said first the wire goes in. After the wire goes in, then we pass the catheters gradually over the wire. We withdraw that wire once we are there. We do not engage yet. Then we connect the catheter to our monitors, okay, for our transducer so that we can see the waveform. And those waveforms are critical to telling us whether we are going on ahead or not. So we pull back the wire. Once we pull back the wire, we connect the waveforms. Then we now adjust our catheter to engage the coronary vessel, which is accessed. Then we'll now do the angiogram, which is injecting the dye and we interpret. So I'll move a little bit faster. Okay, so whenever it's time to do the angiogram, quite simply, most times we like to give NTG before we do that, just to make sure there's no spasm. Occasionally we don't. We've noticed that in Africans, Nigerians, you give a very small dose. This is what is written in the books. But most of Nigerians, you give a very small dose, blood pressure can crash in front of you. So occasionally we choose the patients carefully that we give this. Position your patient, make sure that you are protected, assess the pressure before you now start this thing. Whenever we are giving, we make sure that the contrast that our syringe is facing downwards like this, so that if there's any air bubble, the air gravitates to the top. Okay, but of course we'll have to make sure there's no air in this entire system before we do that. So now we have pushed it in. We typically will make sure that we do a combination of views. Now, when we are doing the views, it's either left or right. Okay, but the left, just to make it more complex so that people will not be able to do, we call it LAO. I'm joking. But left LAO, right RAO. Then whether it is towards the patient's head or towards the patient's leg. If towards the patient's head, we say it's cranial. If towards the patient's leg, we say it's caudal. So it could be LAO cranial, it could be RAO cranial. That is, it means it was towards the patient's head and towards the patient's right. Okay. And it could be LAO caudal, meaning it was towards the patient's leg. This is our cath lab. We position towards the patient's leg, and then we now put it towards the patient's left. So that will now be L. So this combination that helps us to be able to determine. So for the left system, we typically take 5 views. This is what a coronary angiogram looks like. Now, in this case, this is a radial one. As you can see, there is nothing coming from down. okay, for a radial one, and then we have multiple views. The reason you need multiple views is so that you can correctly be able to determine what is there. So for example, in this one, this is an AP view, okay, and then we can see a lesion there, okay, we can see a lesion there, we can see a lesion there. So we do the lesion, the views in multiple views to be able to see, characterize the lesion, and be sure that it's not just one side of view that we are looking at. While for the right coronary, we typically do 3 views, but it could be more depending on what you're trying to look out for or what the particular case for that patient. So if you look at this view, we know we can see how we do the procedure. So these views are simple. Once you've engaged, it is about moving the cath lab in these different positions while you now inject for them. Okay, so typically, you also check that there's backflow. If you give an angiogram and there's no backflow, it means that this your catheter has completely occluded the origin of that vessel. So I hope we can see that. So if we give and there's no backflow, it means this catheter entered completely, occluded, and it means the entire heart is not getting any blood flow. Is that your contrast that you are pushing in? That is deadly. So once you are giving this thing, your mind must be looking for this, and everybody in the lab must also be looking out for this, so that in case you are under pressure, you do not sit, you are looking at one vessel here, somebody else can point it out. So that is why we don't do angios without less than 4 or 5 people in the room and doing different things in the room. So this is, you can see the backflow. You give a good injection, wait for 1 to 2 seconds. Make sure you can see all the coronary segments up to the distal region, okay, and that you have very good projections. Okay, we don't want to be moving around too much. Okay, after you've done that, please look at the pressure again. Sometimes this is a case that I got from online from one of our senior colleagues. As soon as they did the angio, the patient went into Torsades VFib, and this can happen sometimes. And you can see the pressure that was up just went down immediately. Okay, so either from the contrast, either the contrast was given too fast, and so many other things that could happen, patient went to VFib. You can see why you need a defibrillator immediately to be able to do that. So this is one of the complications that could happen, even though coronary angio is largely safe. I told you 99.8% safety, less than 0.2 to 0.5% risks, or sometimes up to 1%, especially patients having an MI, 1 to 2% in an MI. So we've gone through assessment. Now it's time to interpret this angio. If you have any questions, please put in the chat box or in the sorry, chat box has now been enabled. Thank you very much. So somebody says, is coronary angiography a mainstay for diagnosis or more of a therapeutic intervention? Also, is coronary angiograph sufficient? Is CT coronary sufficient in diagnosis? So CT has its limitations. It is not the gold standard, and it typically will depend on the person reading it, and sometimes whether you have very good films and whether the quality of the machine and whether you're able to slow down and even then we've still had cases where patient came with a normal. In fact, the last case I did, patient had a normal coronary CT, but he had a very tight 99% left anterior descending blockage and another blockage, 2 blockages actually. We decided to leave the second one and I stented the first one, but the coronary angio was reported as normal. So sometimes that could be a limitation of CT until you do this. So coronary CT is just to guide us or to help us or to give us more or more in atypical patients that have atypical cases. I'm not talking about that now, so I'm not going to go into the indication for coronary CT as opposed to coronary angiogram. Okay. And I will talk about at the beginning. So if you came late for the person that asked this question, we talked about at the beginning the different reasons why we do a coronary angiogram. And if somebody has an MI, you cannot go and be doing CT because you need to be able to intervene immediately. Another thing is that you are giving dye for both of them. You want to give dye and intervene immediately rather than give a higher amount of dye in CT. So when you are reviewing coronary angiogram, first you need to know the coronary anatomy. There is no way out of reviewing or interpreting a coronary angiogram without knowing coronary anatomy. So, the coronary anatomy, these different segments. We know the left main divided into left circumflex and left anterior descending, and then the RCA continues off, it gives off. You can see the RV marginal, the right ventricular marginal branch. This is the conus branch, which occasionally, and this is the SA node branch. These things, you must know them in your head. It must be clear in your mind as you are doing it. Then you have the left circumflex giving off the obtuse marginal, and sometimes it might give off the PDA. You have the left anterior descending giving off septals and diagonals. We're able to decipher this first part that comes out from the aorta. We call that the left main. Then it gives off the circumflex. This proximal part, we call this the proximal, from the point of origin of the circumflex to the origin of the first OM. We call it the proximal. Thereafter, it's a distal. So circumflex only has proximal and distal, while in the LAD is proximal, mid, and distal. So typically we use the first diagonal or the first septal. Anything before the first diagonal or first septal, we call it proximal. Between that and the curve, mid, and then from the curve downwards, we call it distal. And this is very important when you are naming it for international correlation, and same for the right coronary. And then we determine dominance by which one gives the posterior descending artery. That is the artery that is supplying the posterior interventricular septum. 85% of the time is coming out from the right coronary, okay? However, sometimes it is given from this circumflex in 8%, and sometimes it's co-dominant. One of our people is working on coronary arteries in Nigerians for his PhD dissertation, and will likely come up with that paper very soon for Nigerian populations. Okay, so I will just skip that. So when we want to see how is this lesion severe or not? Is this lesion severe or not? It's very simple. We compare. We compare. We find a reference vessel that looks relatively normal, and then we try and compare. So we are comparing this place that's looking narrowed or tight against this one that's looking relatively healthy. So that is how we are able to compare. So occasionally might have all of them looking like that, then it's difficult to interpret, and the other things we use. But first and foremost, sometimes we compare with just eyesight, or with quantitative measurements. We measured the reference diameter, minimal lumen diameter, proximally, distally, and this tight area, and we do the calculation. Or we do an intravascular ultrasound in addition to that, or we do an optical coherence tomography internally. We pass a wire in and we use an ultrasound inside the coronary vessel. Extremely expensive. I'm not sure there's any center in Nigeria that is doing it routinely or doing it at all currently. And then we are able to determine mild, moderate, or severe stenosis. Now remember that a coronary angiogram is a lumenogram, really. So if you are looking at it from one dimension, even though there's a blockage, it might look normal because you are looking at it over the blockage. That's why you need two dimensions. This one that is looking narrowed like this, when you look at another dimension, you might be thinking, maybe there's not much there. But when you look at it in this way, you can now see. That is why it's very important to have two orthogonal views when looking at a lesion. Okay, so we'll continue. So first of all, we try and interpret. The first question we need to ask ourselves, is this angiogram interpretable? So this kind of angiogram, for example, is not very interpretable. You know why? Some of them do not show this one only show this part and they don't show the distal portion. This one was not properly opacified. So the catheter came out while they were about shooting it and did not opacify. So you are not sure 100% whether there's an obstruction there or not. This one is a deadly one. It's even shooting up at the top of the vessel and came out. Only small went in, and so it's not well opacified. That's one of the first questions you need to ask yourself while you are trying to do. We now define the flow in angiograms into 4 using the TIMI flow system. TIMI 0, no antegrade flow. no anterograde flow. Okay, so that is total occlusion, and this is what we see typically in an acute MI, and I will show you some examples of acute MI that I've done recently, so that we can just appreciate that it's happening in Nigeria. Different patients, some with quote unquote ulcer, and then we went there and we saw 100%. Okay, and TIMI1 flow contract fails to opacify entirely the coronary bed due to a distal to the obstruction. So you have the occlusion here, but distal to it is still not able to get all the bed. We call that TIMI1. In TIMI2 flow, it gets to the end. However, the speed is less, so it is slower in flow than the normal one. So if you compare the speed, typically they have to beat up to 3 times, boom, 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 before it reaches the end, or 2 or 3 beats, while in the normal one, with only 1 cardiac cycle or 1 to 2 cardiac cycles, it gets to the end. So we're able to differentiate these different kinds of flow, and that is very important in grading the occlusion, in prognosticating, and in so many things that we do in cardiology. So, sorry, let me give you the example here. Sorry, why is this video not?
Then studies have shown that it correlates well with the severity of coronary artery disease.
Exactly.
The TIMI flow.
Exactly.
Yes.
Exactly. So if you look at this one now, you can see that there is TIMI0 flow here. Total occlusion of this vessel. This is quite a common thing that you see. This is left circumflex, I think. Yeah, looks like circumflex. Total occlusion there that you are seeing there. So TIMI0 flow. Then pass the wire through, maybe some ballooning has been done, you have TIMI1 flow. This was where the occlusion is. Occlusion has passed, but beyond the level of the occlusion, you still cannot get full flow to the end of the vessel. And TIMI3 flow, it is moving a good flow as soon as you put it, likely after a stent. I can see the stent there. After the stent, it goes all through to the end, okay? So very important when you are interviewing. So when you get a report from us, so again, this is coming from Cardio Care Hospital. Cardio Care Hospital is a center of excellence of cardiovascular healthcare in Nigeria. We are catering to West Africa and to all of Nigeria currently in interventional cardiology, cardiac surgery, and all internal medicine. So we're just going through, for those that just joined us, we're just going through coronary angiogram. So if you get a report that says TIMI0 flow restored to TIMI3 flow, that's what it means. Sometimes it could be TIMI0 flow, and because you haven't presented late, you only could restore to TIMI2. So there's good flow to the end to all the vessels. However, the flow is not fast enough. It is still sluggish and slow. That still correlates with mortality risk. So you still have to be aggressive in your medical management. Okay, so very important to know the difference. So now we'll now look at stenosis in that regard. And I told you that there are different ways of assessing it. But one of the very good ways is just to calculate what is the percentage stenosis. And you do the proximal diameter plus the distal diameter divided by 2. That will give you the reference diameter. Then you now get the minimum lumen diameter and you do the calculation. Typically, that should give you the flow in that regard. So in this case, you can see this is a thrombus. So why do we say it's a thrombus? Very fantastic case which we've done. You can see what we call a filling defect. What we call a filling defect, and I will show you a case where we have the clot. I snapped it for this view. So you can see there's a filling defect. There's flow beyond the obstruction. It's not quite a narrowing of the vessel, but it's a filling defect in that vessel. And after we put a stent, this is a very long stent or multiple stents all the way down. So one of the ways is to try and aspirate this clot, but this clot looks very big. So you try and aspirate it and thereafter put a stent across. So you can see from the initial view how the blood flow was going and not going all the way. So this is like TIMI1 flow. TIMI1 flow. There is flow beyond the obstruction, but it does not go all the way. And you can see TIMI3 flow. You can see how it goes very fast, and you can see all the multiple branches that were not there. Somebody will ask, what is this wire? Who knows what this wire is? Put it in the chat box if you know. Who knows what this wire is? Anybody? Should I put money on it? Should I put money on it? 5,000, 10,000, 50,000, 100,000? Gone. Before somebody quickly answers it. All right. Somebody says an ICD. No, not an ICD. Not an ICD. So this is a wire of a temporary pacemaker. This is a wire of a temporary pacemaker. So when you are doing the right coronary vessel interventions, remember the right coronary is most times the one that supplies the AV node and the SC node. Patients can have asystole. That clot can move and enter one of the small vessels. They can have an AV block. So you typically sometimes will put this precautionary, or if the patient is already bradycardic, you put this temporary pacemaker. That makes sure that the heart is beating throughout the time you're you're walking there. So that is a temporary pacemaker. We'll pass it through the femoral vein, enter the right atrium, enter the right ventricle, and just leave it there. Connect it and then put it on. And it helps to provide that. All right. So sometimes we also have calcification, which is, I don't know if it's very clear, but if you look at this video, even before the dye comes, you can already see the blood vessel. Even before the dye comes, and after the dye, you can see the blood vessel already showing. That is severe calcification. Severe calcification showing even before it. So you are seeing the blood vessels. We have many patients like this. They have severe coronary artery disease for a long time. The vessels are calcified, and even before you do anything, you're already seeing that. And there's ways of classifying this. ACC has type A, type B lesion, and you could also do mild, moderate, severe. The kind of one we saw in that video is severe, which is like a tram track. You can see the entire vessel wall and vessel outline, even in that regard. Number 6 is something that is a very important complication. This could already be there, what we call spontaneous coronary artery dissection, or sometimes it will be caused while doing the procedure yourself. So it's very important for the operator to be able to notice this when it happens so that they can treat it quickly. And there are these 5 classes. For those that are going for exams, this is a very nice question that I would like to ask you there. And if you look here, maybe you need eye of the angel, but let me try and show you. If you look here, can you see this small white line here? And then after it, you can see that there's some contrast being held up inside the wall of the vessel. Okay, so that means that there has been a dissection. The vessel wall, the inner line of the wall has been torn open, either by, sometimes it happens normally on its own, especially pregnant women, people with HIV. It could just be there like that, what we call SCAD, spontaneous coronary artery dissection. And in people that are either pregnant or just delivered, and typically they have no pre-existing coronary condition, as in no hypertension, no diabetes, nothing. So they will have an MI, and then you come in and then you can see that. So you can see that, and you can see that there's contrast. The contrast is staying in between the intimal flap and the vessel. That is why you are seeing contrast hold up. So when we see this, you typically have to act. But in SCAD, the studies have shown that if there is good anterior gauge flow, leave it alone. Don't be tempted. If you try and put in a stent, more dissections will keep on happening, and more dissections will keep on happening. So in SCAD particularly, spontaneous coronary artery dissection, it is not typically done in that regard. All right. For bifurcation lesions, typically is a lesion that happens at a junction. So just think of a T-junction in your town and think of bifurcation lesions. That's what we mean by bifurcation lesions. They are quite nice, they're quite tricky, but they typically need a bigger catheter so that you can be able to take care of the vessels in a way. We have this Medina classification we use to classify bifurcation lesions. It's very, very helpful to classify bifurcation lesions. And it helps us to determine severity, it helps us to classify it, be able to give another person a good report. So if you get a report from us with a classification showing this Medina classification, it's very simple. The first one, and for those going for exams, postgraduate medical exams, very important. The proximal vessel is the first one, 0 or 1. the distal vessel 001 and the side branch 001. So in this case, it's coming like this. So proximal, if there's an obstruction or not, up to 50% or not, distal or side branch. Any lesion that is happening within 2 mm of this bifurcation is considered part of the bifurcation. So you can see that. So if it happens in all three, 1, 1, 1. Only here is happening in proximal and distal. We call it 1, 1, and 0 for the side branch. So this is the Medina classification. It's the most widely used. There are several other classifications that have been proposed and published, but the Medina classification is the most widely used classification in that regard.
It's the most widely used of all the classification.
Yeah, you're breaking up a bit. You were saying that it's most widely used classification. So any lesion that is happening occurring between 3 to 5 millimeters of the origin vessel is called an ostial lesion. I did a very nice case, I hope I have it here, of a right coronary artery ostial lesion, just at the mouth. That was where the lesion was. So there are specific skills and techniques that you use to be able to do a lesion and auto ostial lesion. So it's a lesion from the aorta into the ostium of the RCA. So, but any lesion that occurs within 3 to 5 mm of the origin vessel is called an ostial lesion, and it's very important to note. Okay. This is a complication. You can see there's a stent there. This is gotten from Manobrilakis et al. He published this case. This is a very, very interesting case. According to his reports, they were doing a retrograde CTU. So there was a total occlusion on this side. So they went through the left, went through the back, opened through the back, and then came back to the front where they have opened because they could not pass the total occlusion to the front, had to break through calcium, use balloons and bust it open and crack it open. And then when they finally put a stent and got flow, eventually they had this perforation. And this is showing contrast spilling, which is blood spilling. Now, it's very important for you as the person seeing the angiogram to be able to recognize this. Otherwise, the patient's pericardium will be filled up with blood and they will have pericardial tamponade very fast. So what do we do in this kind of situation? Very simple. This is why when patients are doing an angiogram, they must do it in a well-stocked lab. We typically will have always on hand what we call a covered stent, a stent that is used in this kind of situation. You pass it to that area and put it, and it seals off that blockage. So that is number one, depending on how severe it is. Another way you can do, depending on the severity, and I'm showing you the severity. Another way you can do sometimes is just balloon tamponade. Take a coronary balloon there and then just inflate the balloon to tamponade it till it heals, typically in the mild ones, Ellis 1. But once it is big, you typically have to use a covered stent, and that could happen in different things. Okay, so we've gone through all of these ways through coronary angiogram. Let me show you a case that happened for a 41-year-old chest pain on Christmas Eve. I presented this case also at the Nigerian Cardiac Society meeting. 41-year-old anterior STEMI came in chest pain one day. One of the people that came in early. And as you can see, just like we said, we get the femoral access, and we did that in this case. Now, let me stop sharing. I'm sorry, I want to be able to control the video so that I can see you now, Doctor. Okay. I don't know why I was not able to control the video. Okay, let me try again. I want to be able to control the video. Okay, good. So if you look at this one, if you look at this vessel now, like we can see now, we can see after this is a total occlusion. So how many of us know what TIMI flow level this will be called? Based on our discussion so far, a total occlusion of this vessel, which is called the left anterior descending. What level? Can we put that in the chat box? TIMI 1, TIMI 5, TIMI 6, TIMI 10. Put that in the chat box if you are listening. If you're listening, thank you. I have many interventional cardiologists in the house. I have many. Oh, wow. Yunus Arabi, Obianuju, Ogbobe. Yes, those are the people that are coming to interventional cardiology. Thank you so much. Issa Mohammed, thank you so much. Prof. Sotoye, team is 0. So exactly. So that is very, so we can see that there's team is 0 flow. I had to come out from my Christmas holiday
Thank
for this
you.
case. It was very, 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 it was very worth it. Okay. So can we see that total occlusion? Total occlusion, and it's a cutoff. Now, this is why you must know the coronary anatomy at the back of your hand, because you may not recognize this if you do not know that an artery is supposed to come all the way like this. So now you can see, and then if you look carefully, you will see the artery trying to fill up. That is where the artery, oh my God, what did I do? Oh. Okay, sorry about that. So I now I put something there to just show you where the artery ought to be. And this is just a zoomed up where the artery ought to be. So that's where it ought to be. So now what do we do now? First thing we do is, in this case, we've done the coronary angio. We have seen the problem. The patient is having severe chest pain. He has come in, he's not breathing well. Acute coronary syndrome diagnosis made. So what we do after doing that coronary angio, we change the catheter to the special, not from the diagnostic to a guide catheter. In this case, this is an extra backup catheter. After we have that extra backup catheter, we now pass a wire. Remember the size of the wire we said 0.014 inches. So it's a very tiny wire. In this case, we use the BMW, not BMW like cow. This one is called a balanced middleweight wire, a very good workhorse wire. So we use that and we pass the obstruction. Now, it's very important that when you pass the obstruction, you must be sure you're in the vessel. Occasionally, some people, while doing this, pass outside the vessel, thinking they're in the vessel. When I went for an international conference, somebody was presenting his case from South Africa, I believe, and the person is a very senior person. But somehow, whether it was night or whatever, he passed it outside the vessel and he did not know. He now opened his balloon, like you can see in this image now. The balloon is open there in this image. I can see in this image, the balloon is open there. So he now opened it. Immediately he did that, of course, you have burst the coronary artery and bleeding, bleeding, bleeding. They had to do a lot of things to be able to save that patient. So once we pass that wire, we must be sure we are in the vessel. And there are several techniques we'll do that. That is not for this scope. Then we now inflate, we now inflate the coronary balloon, and you can see this is the coronary balloon. You can see we pass the wire over. Everything we are doing in interventional cardiology, we have a wire typically, and then we are passing things over that wire, acting like a railroad. This is an extra backup. It's giving us extra support at the back so that when we are trying to cross this obstruction, it does not push us out. It gives us support and we're able to pass that. We now inflate this balloon. In this case, we use a 2.5 mm balloon. Now, this inflation is very critical, and we measure the pressure we are putting it in, because we put very high pressure. In fact, it's estimated that the pressure that we put in these balloons is sometimes higher than the pressure in your car tire. So very high pressure balloons sometimes. And then we have different kinds of balloons beyond the scope of this lecture. So then we put the balloon, we inflated it, and you can see there's some blood supply. I hope we can recognize that. Before it was 100%, now we have some blood supply, which we will now call TME1, but it does not go all the way to the end. So what do we do next? Acute MI, we've established some blood flow. We now did a clot aspiration because I believe that there was a clot. So we use a special kind of aspiration catheter. And you look carefully, you can see one small dot moving there. That is the clot aspiration. And you can see this is heavily magnified. This was a clot that came I was able to aspirate from that artery. So after doing that, then we gave the blood flow, and now we can see much better blood flow. Abi, very nice, much better. But there's still obstruction here, but there's good blood flow distal to that obstruction. Okay, and so next we now come and we put our stent. Typically, the left anterior descending is a very big vessel, so I use a 3.5 mm by 30 stent in this case, quite long stent, cover the blockage. And then, boom, we have good flow. But in this case, the flow is good, but it is slow. So it's good flow. We beat 1, 2, 3 before you can see. And this time we cannot see the blood flow very well. So this is like timid 0. So we came back again to give extra balloon to optimize that. And we have, better flow. Not only did we do that, sorry, let me add the other things we did so that it doesn't look like it's just proximal optimization technique. Okay, I wrote it there. Then we gave drugs into the coronary. Now, this is very important. Meaning that you must not just only know the coronary anatomy, you must also know the coronary physiology and how the coronary vessels react. So we gave intracoronary adenosine and intracoronary NTG. Remember, adenosine can slow down the heart. So if you give it to the right coronary artery, you could cause a heart block. But it's transient, but you should be ready for that if that happens. So we give nitroglycerin inside the coronary vessel, then we give adenosine inside the coronary vessel, and then we also did an extra balloon to optimize the stent. That is to make sure the stent is well opposed against the vessel. Okay, and then we can now see the angio. Beautiful, isn't that lovely? Good blood flow, TIMI3 flow going in just once, and then the blockage is stopped. And that's cardio care. For those of you who have not been to cardio care, thankfully there's a video here. That's what our cath lab looks like on our cardiac study theater there. So that's one of the cases that we've done. Okay, I'll take another case as we round up. 51-year-old with chest pain, breathlessness, 7 days, very late presentation. What can we see on this ECG? Can we write on the chat box? We talked about it for those that came in early. For those that came in early. If you have any questions, please put in on the Q&A box or on the chat box. So what can we see on this ECG? Anybody? For those that have been on our webinars, you should be able to do an ECG. For those that attended ACS, South African flag sign. I like that. Jacinta says ST elevation. ST elevation where? We also talked about what we call contiguous leads, meaning that ST elevation should not just happen in one lead, it should happen in multiple leads. Okay, somebody say anterolateral STEMI. Those are senior people. Senior people. Anteroseptal, beautiful, beautiful. Thank you so much. So our ECG lectures have been working. For those that have not attended any and are thinking, how can they read ECG? Just go to our YouTube page and get more, listen to them. So this was the ECG from presentation from the referral center. By the time the ECG came, the segment has started coming down. Already, he's already having full infarction. Q waves are already forming all the way, meaning that he's having a transmural infarction straight from the inner wall of the heart through the muscle to the external wall, a full thickness. So again, similar case. This is the final case, and then we'll wrap up questions. Oops, sorry about that. I was trying to pause. Okay, so in this case again, you can see this total occlusion here, 100% occlusion. Okay, somebody was saying D1. Well, remember that most of the studies have shown in the chat box, but most of the studies have shown that ECG is a poor localizer. It's very important to know, but it's a poor localizer. So it's not D1. This is the entire left anterior descending was gone. So it means all of this part of the heart had no blood supply at all. And it was in heart failure, severe chest pain. Of course, once we opened up, chest pain went down, patient was able to be discharged in a couple of days. Remember, the patient is awake throughout this procedure. We typically don't do, sometimes we give mild sedation, light fentanyl, midazolam, okay? So this is how it is, 100% occlusion. And the same processes we went through in that last case is the same processes we went through. You can see the wire is still inside after giving this one, and then we're able to open up that that blockage. Okay, so I think with that, I will have to come to an end. We spent quite some time, about an hour and a half, so that you are qualified for your 1.5 CME points, but I will take questions. Thank you for listening. I'll take questions. Remember that this is coming from Cardio Care Hospital, Abuja, and we are glad to be here. Dr. Taiwo is there with us, and we're glad to be here to offer these services to your patients when they need them, but also to teach and to make the knowledge readily available to everybody as and when due. So if you have any questions, you can put it in the chat, in the Q&A or in the chat box. Mr. Emmanuel will be putting in the chat box a link to our YouTube channel. A link to, I'll answer the questions now. Mr. Emmanuel will put in our WhatsApp group. So in our WhatsApp chat group, if you're in the WhatsApp chat group, you will get information of our next webinars. You'll also be able to ask questions when you have real life patients. You know, you could ask questions on the group and one of the consultants will quickly answer you. That could be of help to you. And you could ask questions on any topic in cardiology or anything after this webinar. So you could join up there. This is not a full in-depth on coronary angio. This is just an introduction. For those that are in training, there's a more detailed one. Many questions there, many things inside there, which I did not touch here. But from this, you should be able to have a very good, all-rounded this thing. Dr. Ajala, thank you for joining us. Dr. Ajala has a question. Dr.
Thank you
Taiwo,
all for joining.
Can you see the question, Doctor? Dr. Taiwo, you know Dr. Ajala now. Can you see her question? She says, what's the use of the IV adenosine? We did not give the adenosine IV, sorry, Dr. Ajala, it wasn't IV, it was intracoronary. Intracoronary. Dr. Olua wrote to me. Nice to see you. We did not give the adenosine IV, we give it intracoronary, not IV. We give IV if you are giving, you are treating a supraventricular tachycardia, you're giving it very fast. But in this one, we're giving it intracoronary. And the idea behind that is to cause coronary vasodilation, okay, so especially for the microcirculation. So there are different interventional cardiologists that have different beliefs. Some people give it in every case of MI until they see bradycardia, because they are now sure that it has caused some microdilatation of the small vessels. So besides opening the major coronary vessels, we're also worried about the smaller microvasculature of the coronary vessels. That's one. Two, there have been a lot of studies about using intracoronary adenosine before you stent, and it has been shown to reduce a phenomenon that we call no reflow syndrome, which is whereby we inflate, we put the stent, and then there's total occlusion. The patient does not have any flow, despite being there's no obstruction. So that no reflow phenomenon has been greatly reduced by intracoronary adenosine. So that is are there contraindications to coronary angiography? Yes. If the patient does not need it, you should not do it. If the patient has what they call it, severe kidney disease, you should be worried about it. If it's not an MI, you're very wary, because if their creatinine is high, that could worsen it, you know. Am I still on? Hello? Okay, I think I'm still on. Mr. Emmanuel, am I still on? You have done something, you have signed me out of here or something. Am I still on? Can you hear me, please? Okay, thank you. Somebody said I'm on. Thank you. All right. What was I saying? I was answering a question. Contraindications to coronary angio. Yes. So patients with CK. So there was a patient that came to me from, I think, Liberia or from Zimbabwe. I can't remember. One of the African countries. Like a month or 2 months post MI. We're supposed to do the angio, but the creatinine was 3. So creatinine of 3, in that kind of regard, is one of the contraindications. You may not want to go ahead with that. Patient is having, severely elevated blood pressure. You may have to, and there are so many others. However, in the setting of an acute MI, we manage most of those conditions and treat, because the benefits outweigh the risk. So in other words, anytime the risk outweigh the benefits, we do not go ahead with a coronary angiogram. And sometimes too, if you know you're just doing a coronary angiogram just for study's sake, no plan and you're not sure that it will give you any added advantage or any added information, we will not do. There was a patient I wanted to do that we suspected having a SCAD, a spontaneous coronary artery dissection. Pregnant woman, delivered, had a cardiac arrest, severe chest pain, troponins high, but they don't have enough money for a lot of things. But we now thought, even if and the patient was now stable, we are stabilized medically and wanted to rush into the cath lab. Even if we went there and we saw the SCAD because she had no this, we will not do anything. She's fine, troponin is down, everything is fine. So some of those things you have to weigh them and weigh the benefit versus the risk of all of those things. And that's particularly it. So let me see if there are any other questions for me to answer. Mr. Emmanuel, can you please put the link to the WhatsApp group in the chat box so that people can get themselves added to the chat group? And then if they have any questions, they have difficulties, they can reach out to us. And if they have patients to refer as well, they can easily reach out to us. Okay. I can see there are 16. Oh, let me go. Okay. Residents for training in interventional cardiology. So yes, right now we are doing some form of postings for part 2, pre-part 2 senior residents in cardiology, in cardio care, yes. However, we are hoping that before this year is over, we should have completed the process we have been working on with the National Postgraduate College of Nigeria. Once that is done, we will make the necessary advertisements so that people can come for a fellowship and get that. But however, people are welcome to cardio care in that regard. Okay, so let me see the other questions. Other question is, what's the average cost of a procedure? Coronary angiogram varies in cost across Nigeria. Cardio care is one of the main places that does in Abuja and in northern Nigeria, typically somewhere between 1.5 to 2.5 million for an angiogram only. Okay, and then if there's a stent needed, it typically costs some more. But remember that it's a life-saving procedure. Unfortunately, everything has to be imported from outside the country, so that also affects our cost with terms of dollars. I had a CT coronary angio done for recurrent chest pain with normal ECG. The findings were normal. I still have dyspnea from time to time. Coronary angio, the CT coronary angio done. And do I still need one? So remember that a CT coronary angio, like I said during the presentation, is not a definitive diagnosis. Like I said, the very last case I did, the CT coronary angio was normal, but the man was still having chest pain, he's diabetic, and we were, from clinical and otherwise features, we were sure that there should be something there. So despite a normal coronary angio, we went in, and like I said, he had 2 vessel disease. I stented one of them in the left, which was 99% blocked, and not just small blocked, it was blocked for a long period. So for a long, I say long period, a long segment. So I put in a stent and the man is much, much, much better. So CT coronary angio is not a definitive test. It's very important, especially in patients with atypical chest pain, in patients you're suspecting other things, or as a first-line investigation, you're not sure. Okay, so you can do, and maybe we'll talk about CT coronary angio at a different time. Hopefully, by God's grace, we'll be able to get that done in cardio care very soon. So, Mr. Emmanuel, a lot of people are asking for the link to the WhatsApp chat group. Otherwise, you have to add them manually to the WhatsApp chat group. All right. How do you differentiate SCAD from iatrogenic one while doing? It's difficult. The main difference is that the question is, how do you differentiate the dissection that was spontaneous from iatrogenic? Okay, so it's very important that when you do your initial angio, you take your time and critically look at it very well. Typically for spontaneous coronary artery dissection, you will see the dissection there before your interventions. So before you start intervening, you will see the dissection there. Sometimes you see it in hindsight. You were so busy looking at something else that you did not see it. So, but typically you have to take some time and look at it. While the iatrogenic one typically happens after you pass a wire, or after you inflated a balloon, or after you deployed a stent. Sometimes it is so minute that you may not be able to recognize it with your normal eye. And in that case, that intravascular ultrasound, which is you pass like an ultrasound probe into the coronary vessel itself. Once you pass that probe into the vessel, you will now do an ultrasound of the coronary vessel, and you will see all the flaps of the vessel, and you can see even the small dissections in that regard. So more often than not, when we see it on the normal one, we normally proceed with an IVUS, intravascular ultrasound, to be able to diagnose it. And typically the main difference is one was there before you did anything, another one was there after you did something. Now, it is not uncommon to have dissections while you're intervening, especially when you are doing very complex cases or especially very calcified vessels. But what is more important is that you notice it immediately and you treat it immediately. Okay, so occasionally, once in a while, 1 in 1,000 once, depending on how many complex cases you are doing, you will come across it in your practice. And once you see it, important thing is to recognize it quickly and then do what is necessary before it becomes severe or causes any problem. Okay, so I think I've answered most of the questions. For those of you that have not been to the cath lab before, you could, if you're in Abuja or nearby, come around. If you're having a case, we'd like to have you, and then we'll be able to. If you've been to a cath lab now, you're doing a coronary angio. After this lecture, you'll be able to understand it. Remember, we'll have this available also on our YouTube page, so you can watch it again and again. Sorry. So you can watch it again if you missed a significant part of this presentation. So if you missed it, don't worry. Just calm down. You watch again, and you will be able to see it. Remember that cardio care is located in Abuja, and quite a number of cases. So including devices. Right now, I'm still in the cath lab, although I'm in another cath lab. The pacemakers, ICDs, and occasionally we have support from Cardiovascular Education Foundation or from other philanthropists that allow us to be able to do stuff for free for people that are really indigent. So sometimes we're able to do stuff for free. And you can see an ICD that helps to prevent sudden death. This is CRT. You can see the wire into the coronary sinus. This is another device that we use for a heart failure, typically advanced heart failure. And we are glad to announce that Cardiocare and the Pioneer Hospital to do the first ever left bundle branch area pacing in the whole of West Africa and Nigeria, almost sub-Saharan Africa, except Kenya. I think Kenya has done before Nigeria, but we're able to do that last year, and we're very happy to announce that we're Pioneer Hospital in left bundle branch area pacing in Nigeria and West Africa. And we hope to continue to be a center of excellence to bring multiple things to you. And the thing about left bundle branch area pacing, the most important thing about it, and these are some images, that after the pacemaker is inserted, the patient has a narrow QRS. So when a patient has been on a pacemaker for a very long time, most of them will develop a heart failure as a result of the way the pacemaker is pacing. So for those that we think they will be on it for a long time, it's very important to put a left bundle branch area pacing, and it could really help in a number of things. And I've showed you all these other cases, but I want to show you one case of a renal artery occlusion, 100% renal artery occlusion for a patient. This patient, apparently we had put in a stent for him for his left anterior descending, and then he came back 2 years later, while on drug, developed a renal artery occlusion, which he was rushed in, and then we had to work all night to achieve this, and was able to be discharged the next day. So this would have been a lost kidney completely. But what are we able to find? It no blood flow at all in that kidney, and then we're able to restore blood flow. And also pulmonary embolism. This is a massive pulmonary embolism with no blood flow completely to that left lung. But after the procedure, which is we do multiple procedures to be able to achieve this, we are now able to restore flow to that left. This is very significant. Even right on the table for this patient, the pulmonary pressures start dropping, start coming down. But just like we do in the coronary vessels, we can do in the peripheral vessels. As you can see, this is a stent being deployed in the anterior tibial artery, and that really restored this man's leg from this almost black nature, almost getting to gangrene, to this almost 2 weeks after. Okay, so very important in that regard. So with this, I will end this presentation. Thank you all for joining. I'm sure you had a great time. I think we've answered virtually all of the questions. But if you have any more questions, you can send to our mail, and then you can join the WhatsApp group, and then you can put in your cases, or you can contact us directly. And we'll be glad to have your patients that do need it, especially those with heart attacks, that need pacemakers, and all of the like. Thank you so much. I wish you a lovely weekend. For those of you that are going to weekend, for us, I'm continuing working. I think I still have 3 more devices to implant. So wish you all a very lovely time. Thank you. Have a lovely day.
Thank you all for joining.